voice clear? Salam from Indonesia. I have my time to presenting my paper, my case report about the non-invasive ventilation as an alternative in improving diaphragm movement, peak flow expiration, and end-tidal carbon dioxide of the laryngectomy. My name is Siti Chandra. I came from Persahabatan Hospital, one of the largest respiratory center in Indonesia. And I'm working also in University of Indonesia, and this is a case report of about the laryngectomy or person with laryngectomy, which we've been handling from before this pandemic. This is my abstract about laryngectomy, that person who have laryngectomy may have problem with the lung compliance, and that's due to the diaphragm increasing resistance. That can cause in the increase of CO2 and tidal, and the for us the NIV is according to the theories can be improved lung compliance. So we can use this in the for patient in outpatient to improve their lung compliance, the end result of end-tidal CO2 correction. This is a case series of 3 patients that we report the effect of NIV on several lung function parameters. Suppose that's good enough, and we see that in clinically there is a good result in regarding the diaphragm compliance and the CO2 and tidal. But this is only a case report, so we need another patient to get more greater result. We can do the background that we need proper breathing pattern to allow greater utilization of lung compliance, because an optimal lung compliance is needed to perform several activities in patient after taking a laryngectomy. Usually this patient, they have good stomach after taking care by our ENT doctors for the post-operative or post-laryngectomy, but they have some other problem when they come to our department in rehabilitation department, such as mucus clearance ability. Those laryngectomy patient has a problem about the ability to maintain those lung compliant, how to exsufflate and insufflate properly. This caused by the less recoil of the thoracic component and the increase of work of breathing, because there's a big stoma and as a something of their airway. So it's gonna be increased work of breathing for the breathing muscles, and especially for the diaphragm as the primary breathing muscle. So in this case series, we try to explore in the immediate effect of application of the non-invasive ventilator treatment for the laryngectomy patient. Our method is at this time for this case report, we put 3 laryngectomy patients who came into our pulmonary rehabilitation outpatient clinic after the stoma wound is already healed. Then the ENT referred to us about the breathing training, the pulmonary training after they were giving. Also, they have given treatment as a cancer patient. All these patients receive standard endurance training, rehabilitation training for their endurance in daily living. Then for after post-laryngectomy due to the laryngeal removal because of laryngeal carcinoma. Then we give them application of NIV through the laryngectoma. We give those each of them immediate effect of the NIV through the stoma 5 to 10 cycles in this same day. Then we measure the parameter before and immediate after the application of the non-invasive ventilation. We do the non-invasive ventilation to inflate and deflate the lung to maintain or to stretch the lung compliant. We measure the end-tidal CO2. We have the non-capnograph to measure the end-tidal CO2 of this patient. Then we also measure the peak half flow. This is a peak flow meter that we do the half because the patient cannot able to cough again because they already got a laryngectomy. So we put those peak flow meter in the stoma, laryngectomy stoma. Then we ask them to make half through the stoma and through those peak flow meter. Then those half, we know that they have peak half flow through the peak flow meter, and we record that before and after the application of those non-invasive ventilation. We also measure the diaphragm movement using the MOT ultrasound before and after the application of an NIV. Usually, when we do not use the NIV, we also use the positive ventilation using ambu bagging for maximum insufflation and exsufflation exercise for those patients when they can do it at home for their home exercise. In a result, the peak half flow for those patients, this also observed there is increase about 336.6 liter per minute and up to 350 liter per minute. And also the end-tidal CO2 monitoring mean is between from the start point is 66.67 meter and decreasing into 33.3, and this is gaining the CO2 washing out in all patients. The diaphragm velocity also increase, about increase on 170% increase in velocity from 2018.9 centimeter per second to 3,373.47 centimeter per second. When also my diaphragm thickness also increased from 2 centimeter to 2.97 centimeter. Of course, this is only a short period of time. We need to take longer monitoring for those patients and a proper monitoring for pulmonary rehab, but we have as the beginning for our case report that this is we can do for them to decrease their work of breathing in the long-term period. And the result that we give, this is this patient that we got give them the NIV. We use it through the stoma, and we do it the short term of NIV application can be beneficial, can be applied to improve the carbon dioxide washing out and also increase lung compliance in laryngectomy. A clinical trial with sufficient number of patients and more proper method is needed to give evidence for those laryngectomy patients, and we hope this is the beginning that we can do for all patients with this post-laryngectomy. Even in this period of pandemic, we cannot use those methods directly, but we can properly ask the patient individually do it at home with the ambu bagging for positive ventilation to assist the lung to inflate and to decrease the